right, I think we will go ahead and get started. So thank you all for joining us this evening. Welcome to the sixth and final module in our Business of Medicine series put on by the Washington Academy of Family Physicians. This module is kind of a summary conclusion module for the entire series. So the title for this one is Pulling It All Together, Leverage Your Knowledge to Improve Patient Outcomes and Your Professional Satisfaction. As a reminder, this meeting is being recorded. As always, we'll do some question and answer at the end, but we'll save questions to the end just to support the recording itself. So our agenda for this evening, very similar to the last few sessions. We'll start with some basic introductory comments, similar to the ones that I've made with each previous module. We'll do kind of a quick review of the prior 5 sections, really just kind of hitting the high points. Obviously each of those was about an hour long, so a lot of detail there, but we'll just kind of do a high level review. We'll then move on to the meat of the presentation this evening, which is really around case studies, and it's really built around specific problems that some of the problems my organization, Family Care Network, has faced, and sort of how we thought through and worked through those problems. And then there were a couple, or actually a handful of suggestions from participants. So we'll walk through one in a bit more detail, and then I'll give some thoughts on a couple other scenarios. And then we'll conclude with 5 take-home messages from the Business of Medicine series, and then do question and answer at the end, as always. And then that will wrap this up. So as a reminder, videos from the first 5 modules are posted on the WAFP website. That is the URL there if you're interested. And these videos will continue to be posted for the at least foreseeable future as a resource to family docs from around the state. So just as a reminder, goal of the Business of Medicine series. So really, why are we putting this on? I know many of you have joined us throughout this series, but in 2 words, the goal of this series is around physician empowerment. And it's really built on this idea, this premise that with additional knowledge and understanding, that family physicians will feel empowered to regain a sense of autonomy and control, which they can then use to improve patient care and increase professional satisfaction. And again, the case studies tonight will really focus on that, sort of how these problems were addressed. And again, for the ones for Family Care Network, how we approach these things and what the eventual outcome was. Just as a reminder, this series is put on by the Professional Affairs Committee, which is one of the subcommittees of the Washington Academy of Family Physicians. These are the members that are on the call tonight, continuing to support this effort. As a reminder, if you do have questions during the presentation, feel free to drop those into the group chat, or if you care to remain anonymous, you can send those questions to Jordan directly, and then he will facilitate the question and answer at the end. And I want to say a huge thank you to this group. It's being at the conclusion of this series, reflecting that this started with an idea about a year and a half ago, when we as a group kind of came together and started to brainstorm, how do we empower family docs across the state who feel a loss of empowerment over the last number of years or last couple of decades. And this series is just one of the ideas that emerged from that. So it's should have been a long time coming with a lot of input from different folks, but this has kind of been the primary team that has created this. So huge thanks to Jordan, Lynn, and Alyssa for their support throughout. As always, conflicts of interest, I do not have any, but as always, strong opinions, I do. And I'll just reiterate, as I've said each time, if you get 10 different people to teach this series and they'd sort of walk through it 10 different ways, and one would not be more correct than another. So much of what you'll see tonight or hear tonight, again, is my sort of impression and take on these things. And so we started this series with this kind of fairly simplified picture of what healthcare looks like today. So 3 different main groups of provider organizations. Those are physician groups, hospitals, et cetera. Payer organizations, so these are the insurance companies, and then obviously patients as the third party. Throughout this series, we focused on different components of this chart. Tonight, we'll really focus kind of primarily on how we leverage all the information we've learned to the benefit of patients, and then really to the benefit of providers as well. So I see a typo on the top of this. It says the focus today is payer organizations, but the focus today is really on patients and directly on providers. So what have we learned so far throughout this series? So again, kind of walk through one key take-home message from each of the previous 5 modules. So the first one is that healthcare companies largely want to provide good care, but they must run financially sustainable businesses. So I hope you all remember this kind of scale picture where organizations involved in healthcare have to define success, and generally success is defined somewhere along the spectrum between running profitable, growing, vibrant businesses, but then also providing direct patient care. And I think we outlined there are moments when those goals align, but there are plenty of moments when those goals are in direct conflict. And I think one sort of big take-home message from the first module is that it's really not one or the other. There has to be kind of a balance between these two. So an organization that's fully built on profits will alienate patients and eventually not have patients to care for. Conversely, an organization that only focuses on patients and doesn't pay any attention to the underlying business fundamentals will not remain in business for very long and won't continue to provide that care. So the real dilemma is how do we keep these two things in appropriate balance? I think our hope as Family Docs is that all of our organizations lean towards care of patients as the primary goal. I think we've all had experiences in healthcare that demonstrate that that is not always the case. Second module, we focused kind of on healthcare becoming big business. So I think, as you all know, many healthcare companies are now huge, hundreds of billions of dollars in revenue, publicly traded companies. And these companies use leverage as influence on payers, physicians, and patients. And we talked a bit about the consolidation that's happened in healthcare over the last number of decades. And you remember this picture where originally each of these hospitals and each of these clinics was a different color because they were owned and operated by different entities that were competing in any given market. And over time, consolidation has led to market-specific monopolies, sometimes regional or state-specific monopolies. And I think one of the messages is as much as healthcare would say, yeah, we'll just use size for economies of scale and create better patient outcomes with cost-effective care. I think what we have seen pretty clearly over the last 20, 30 years in healthcare is that monopolies in healthcare are very similar to monopolies elsewhere. They jack up prices and quality often doesn't improve as well. So recognizing that as providers, we're often fighting against these big systems. Patients are trying to navigate through these big systems. And obviously it's a huge challenge for many involved. Third module, we talked about understanding the business models of healthcare companies and insurers and how that's critical to making sense of the decisions they make. We talked a little bit about this real basic financial model that you've got revenue, less expenses, and that defines profit or loss. And at a very fundamental level, any business can't run at a loss for an extended period of time and remain in business. And so, again, not every healthcare company has to be purely focused on driving, huge profits, but they have to be at least somewhat profitable in order to sustain themselves over time. And we took a look at where that revenue comes from. And again, that relationship typically between payers and healthcare providers and different contractual arrangements. And then again, I think the expenses piece is a little bit more self-explanatory. All the expenses that are associated with running a healthcare organization or an insurance company as an example. And then we looked at one specific contract. So this is an overview picture of Making Care Primary, which I think you all remember is the new CMS pilot program for traditional Medicare. Washington is one of 8 pilot states, and I think you all probably recall or know that traditionally Medicare has been a fee-for-service only program since it was founded in 1965. Making Care Primary radically changes that to a payment model that's got a monthly capitated payment. They've got some carve-out services that are paid above the cap. There's HCC risk score-based enhanced payments that come on a quarterly basis. And then there's also performance incentives based on preventive care, chronic disease, and utilization metrics that are tracked for your panel of patients. So again, kind of a layered contract. And again, to sort of win or do well in those contracts, you have to pay attention to each of the individual pieces and have strategies built around performing as well as possible on each of those individual pieces. And then we talked a little bit about healthcare executives, whether they're in healthcare provider organizations or insurance companies, how they must run financially viable businesses and how they face certain constraints and incentives in doing so, and how understanding these constraints and incentives is really critical. And we'll lay that out in the case studies tonight, kind of how you make a case in talking with these executives to advocate for change. For healthcare executives, we talked about this sort of picture of an old fee-for-service world. That's how healthcare was a couple decades ago. And if you sort of step back and look at sort of older healthcare institutions like many large hospitals and such, they're really built for a single purpose, which was around generating more work RVUs. That was the compensation model, right? Every RVU you generate, you are paid for that RVU. So the goal is to generate as many RVUs as possible. That led to a heavy focus on hospital, procedural, specialty focused work. And there wasn't a whole lot of attention paid to cost. It was sort of like, well, if things cost more money, that's okay as long as we're generating more RVUs and driving more revenue. The future world, and we're kind of in the gap here between these two, is very much a value-based care world. I think we've all heard that term. We talked about how it's difficult to concisely define value-based care, but in essence, it's care that has measurable positive outcomes in the most cost-effective way. And so a value-based care world is really built around lean organizations, not these historic organizations, built around patient-centered care, and really requires high-functioning primary care as a key to success. And so again, part of my belief as to why now is such a great time to be a family physician. So I think that's the challenge for healthcare executives, is sort of crossing this bridge from the old world into the new world. And then we talked about for insurance companies, sort of their challenge and how obviously they have a bunch of different levers they can pull across the different insurance products they may offer, be it commercial, Medicaid, or Medicare Advantage. And they're looking to sort of dial it just right to maximize overall revenue while still effectively managing cost. And again, that's their challenge. You see that played out in all the different insurance products, different insurance plans that are out there in the market, and all the different benefits and all the different financial components of those. So again, it's executives and payer organizations trying to figure out, how do we set these dials just right to maximize our revenue generation. So again, that's kind of a high level overview of the ground that we've covered so far. Obviously, in 5 or 10 minutes, we can't go very deep in it, but to give a framework to inform around these kind of case studies that we'll walk through. So first, some introductory comments or general thoughts about creating change. So, I think we all recognize that healthcare is broken. I would imagine everybody who's on this call is interested in being a force for positive change in healthcare, both for care of patients, but also for our own sanity and our own professional satisfaction. And so a few comments. First, in order to solve problems in healthcare, you must think beyond your personal perspective to understand the perspective of the various decision makers. This includes understanding the past history of decisions, so why things function the way they do today, and then the current realities of these decision makers. And so I often hear physicians, not just family physicians, but all physicians, complaining about kind of the way things are, but never really taking the next step to ask, why are things the way they are, and why do they perpetuate the way they are? And a big take-home message is that there's a reason and there's an answer. I mean, somebody made a decision at some point in time. Somebody is reaffirming that decision on an ongoing basis. And so rather than just sort of throwing arms up in a defeatist way and saying, it's broken and this really sucks for me and it's terrible and such, I would really encourage anybody who wants to be a force for change to think through, why is it built this way, and to understand, like, there is so much money in healthcare that things don't happen at random. Like, generally speaking, there's some thought behind it, and an intentional decision has been made by whoever those decision makers are. So you have to step outside yourself and see it from the perspective of others. That's sort of step number one. Second thing I would say is that publicly, everybody involved in healthcare professes to prioritize patient care as their primary goal. And that sounds really, really basic. Every mission and vision statement for every healthcare organization I've ever come across talks about patient care, and we serve patients, and every touch and every time, and it's all about patients and such. We've found at Family Care Network reminding organizations that this is your goal, that this is their stated goal when solving problems, can be helpful to create an alignment. So again, we as family docs want to take really good care of patients, and sometimes it's us reminding insurance companies or local hospitals, hey, if you really wanted to take really good care of patients, this is what you would do. Sometimes that leads to easy alignment around a certain plan or certain solutions. Other times, I'll be honest, it creates kind of an awkwardness in the conversations, but it kind of calls out BS sometimes the BS that exists sometimes in healthcare organizations and creates a sense of accountability. So that's ammunition that we're never afraid to use. I think people know that docs go into family medicine because they care first and foremost about the patients and the communities we serve, and reminding everyone that should be success in healthcare. Maybe it's not for you, but it should be, and it's in your mission and vision statement, so let's align around that. So again, powerful piece of ammunition. Fourth point, solving big problems in healthcare requires creative thinking that is sometimes outside of the traditional box. And I know that's, a very common phrase. We need some outside of the box thinking, but healthcare has plodded along in a certain way for a very long period of time. Change is very, very slow to happen in healthcare. But again, if you understand the forces and the dynamics and the decision makers and the constraints and the opportunities and such, sometimes through that emerges some options or some solutions that are really different than the way people have thought of things before. And so again, stepping outside of your current frame and your current lens to think, is there a totally different way to accomplish or to solve this problem or accomplish this goal can be really helpful. Easier said than done, but can be very fruitful. And then finally, and this is a huge one, is I would encourage you in these scenarios to look for win-wins, or sometimes it's win-win-win solutions. So good for providers, good for the organization, good for patients, maybe good for payers as well. So often we fall into these patterns of kind of win-lose thinking. So I'm going to go negotiate with my employer and I'm going to get more things and it's going to cost them more money and such. You can do that, but that's a tough road. I mean, that's a really hard road to go down. If you can make a case to your employer as to why what you think is good would actually also be good for them, you're going to get a lot more traction and more likely have success. So again, in so much as you can find those win-wins or win-win-wins, you're gonna make a lot more forward progress. And then this is a final kind of screwy thing that I've learned over the last 5 years in my leadership role is that often you have to solve the business problems of other decision makers in organizations outside of your own, and then explain how your solution helps them. And that sounds nuts, but I can't tell you how many times we at Family Care Network have gone to health insurers, other local healthcare companies, and said, essentially, help us help you. We have a plan or a solution here that would be good for you. Help us implement it. Yes, it would be good for patients and it would help us as well. It would be good for our providers and such, but here's a roadmap for you to succeed. I've been astounded how often healthcare organizations, these could be physician groups, hospitals, payers and such, don't have clarity around a plan and a strategy and a way to achieve success. And one of my huge frustrations in healthcare is the short-term thinking that many healthcare executives operate under. And it's sort of the don't have to be a publicly traded company to think quarter to quarter. But really in healthcare, I mean, change is slow, right? We're dealing with human beings. We're dealing with very complicated, heavily regulated industry. And so we have to be thinking in years increments. So, where do we want to be in a year, 3 years, 5 years, 10 years, even sometimes 20 years? That should be a part of the conversation. It rarely is. But if you can help define this is a strategic approach that would make you successful over time, and you lay that out to whoever it is you're talking to, that often can gain a lot of traction. And again, that can very much become that sort of win-win. So those are some initial thoughts. Let's dive into 3 specific case studies for Family Care Network, and they'll follow kind of a similar format. And the idea here is to just kind of get us thinking a little bit. In a classroom setting, we do more of an interactive, but I'll just kind of walk through each of the pieces here. And so we'll start with the first one, which was for Family Care Network, overutilization of emergency departments after business hours. And so the problem, put simply here, was that Family Care Network's outpatient clinics were typically open normal business hours, 8 a.m. to 5 p.m. Some stayed open a little bit later than that. FCM providers were typically on call from 5 p.m. until 8 a.m., but there were no options locally for patients to receive in-person care during those hours. So those are again, not outside of the traditional business hours. And so that resulted in patients visiting the ER for problems that could be managed in an outpatient setting that really didn't require an ER visit. But again, we had no appropriate outpatient settings. And so Sometimes that was patients just going to the ER. Often it was patients calling the on-call FCN provider, the provider saying, somebody really needs to look at that, or somebody needs to run a urine dip on you, or somebody needs to run a quick point of care flu test or something like that. But we didn't have any resources to offer. There were times when FCN docs would actually drive into their clinic and tell the patient, it's 10 o'clock at night, just meet me at the office, I'll let you in and we'll run this test. But again, that's not really a long-term sustainable approach. And so before we think about options and solutions, I talked previously about sort of stepping outside of your own experience and saying, what are the perspectives of other potential stakeholders here? So let's walk through those as an organized way of thinking. So patients were often forced, I put that in quotes, into ER visits. And I think, as we all know, being in an ER is generally a miserable experience. It's also unbelievably expensive. ERs are not known for doing limited care. They do kind of anything and everything for patients. And so very time consuming, frustrating experience for patient, long waits in waiting rooms, and huge bills that they would get as a result of it. So clearly patients were motivated to try to figure out a different solution to this. Providers, so these would be the FCN physicians and our other providers, frustrated by having to direct patients to the ER, recognized that this was not the appropriate location for care that was needed. And generally speaking, our organization has been really attuned to the fact that healthcare needs to be operated in the most cost-effective way. And I think you all know that sort of means the right care at the right time, at the right place, done by the right provider and such. This was clearly an instance where we were being forced to send patients in a direction that wasn't in line with that goal. So providers were really motivated to try to come up with a better solution for patients. Payers, this was an interesting one. So we partner with insurance companies. So despite many patients having high deductible health plans, which I think you all know, that means the initial burden falls to patients, single emergency room visits can frequently exceed the annual deductible, meaning that the insurance company, the payer, was then paying to cover portions of these unnecessary ER visits. So interestingly, payers themselves were super motivated to try to keep patients out of the ER. They were always telling us, God, we got to manage admissions. We got to work to keep patients out of the ER, because they knew that it just drove up expenses for them. And again, they were trying to run sustainable businesses as well. And then the other portion would be local hospitals. I think you all know ER docs and local hospitals not super excited to deal with non-emergent things in ER visits. I think every ER that I know of almost is understaffed and overburdened and such. So the local hospitals would be hugely supportive of trying to figure out another solution. So again, we have a problem. It's really not working for any of the stakeholders involved, but nobody had come up with a better solution or plan to fix it. So we started to brainstorm potential solutions, and this is not a comprehensive list, but this is just a couple that we came up with. So the first one would be to extend clinic hours. So maybe instead of closing at 5, our clinics would close at 8 or 9 p.m. or something like that. That could work. It would be good utilization of buildings that we were already paying rent for and such. Not terribly popular with physicians. Potentially also some staffing difficulties, right? So you can't just have the docs there. You need to have front desk staff, you need to have nursing staff and such. So a potential idea, some significant hurdles to that. Launch our own urgent care center or urgent care centers. The dilemma with that was just the startup costs are significant, right? So before your very first day of opening the doors, you've put a lot of money into finding a space, improving that space or remodeling that space, hiring providers, building out workflows, hiring front desk staff members and clinical staff or nurses, training them for those jobs and such. So pretty substantial startup costs associated with that. We did a bit of a pro forma around launching our urgent care, and what we figured out pretty quickly is that if we could come up with a solution for the startup costs, we probably could make it pencil on an ongoing basis. That is, the revenue would cover the cost, but it was that startup cost that is just sort of a flat fixed cost that was a barrier for our organization. Another option was to try to convince the local urgent care centers to extend their hours. Oddly enough, some of them kept those same business hours, which always seemed a little strange to me, but asking them to work into the evenings or work through the weekends would have been a challenge. We also weren't necessarily totally confident in the quality of care that these local urgent cares would potentially provide. One other idea we had was to try to recruit other urgent care centers to come to town. Again, we didn't think we'd have much success with that. And I would also call out that this was pre-telemedicine. So this was in the early 2012, something like that. And so again, those were the options that we came up with. And so in thinking those through, we ultimately landed on the second one, that we were very interested in launching our own urgent care. But again, those startup costs are a barrier. And so you say, well, what do you do with that? So this is kind of the story and the outcome. So FCM decided that we'd like to launch our own urgent care centers, but the startup costs were a barrier, recognizing that having urgent care centers would reduce ER visits and save money for payers. We actually approached each of our payers, went to each of our payers and asked for an initial monetary investment to cover those startup costs. So we basically went to them and said that having an urgent care center or urgent care centers would reduce unnecessary ER visits, improve patient satisfaction, something that payers are always motivated by, and ultimately save them money and improve their bottom line financials. We also negotiated with payers in advance appropriate reimbursement rates for our or for our urgent care visits to ensure that we could make the urgent care center sustainable over time. So we actually negotiated the new contracts where we said not only going to give us money up front, but you're going to pay us an appropriate rate for urgent care services, and we're going to commit to that moving forward. Interestingly, our payers were, maybe not interestingly, our payers totally supported this idea and contributed several $100,000 financially to cover a significant portion, in fact, almost all of our initial startup costs. And so ultimately, obviously, these services were of great benefit to our patients, to the community as a whole. Our docs loved it because it gave our on-call providers another option for where to send patients after business hours. And again, it really became kind of a win-win-win, right? So good for patients, good for FCM providers, good for insurance companies. Our big barrier was money. Insurance companies have money, and they were the ones who really stood to benefit from a reduction in ER visits. So we just went to them and said, hey, you want to save money by keeping patients out of the ER? Here's what you need to do. You write us a check for a few $100,000. We'll get this thing off the ground, and then you will benefit for years moving forward as a result of having the urgent care center. So FCM story, we started out with one urgent care center in Bellingham. We've now expanded to 3 urgent care centers across Whatcom and Skagit County. They're not open 24 hours a day, although we continue to slowly expand those hours. Current plan is for them to be open 12, 13 hours every day, something like that. Varies a little bit on the weekends, but again, continues to be a massively beneficial service to our patients. So that's the first case study, again, trying to overcome ER overutilization and really trying to get somebody else to pay for it. So I'll move on to the second one. Again, if you have questions along the way, drop them in the chat. We can circle back around to these. Second one is around mental health access problems. So this is not a new problem. This is an ongoing problem. FCM providers, physicians, nurse practitioners, physician assistants could not find reliable access to mental health services for their patients. It was recognized that this lack of access was reducing overall quality of care, but also increasing costs primarily through greater use of ED services. So we as an organization did a study a number of years ago looking at why do our patients go to the ER? And in very broad sweeping terms, we found about a third of the patients very appropriately went to the ER. About a third of patients went for pain management, kind of medication management issues. Most often it was pain management. And about a third went for untreated mental health related issues. And so again, potential for huge savings there with ED services. So stakeholders, patients with appropriate mental health resources, or excuse me, I should say without appropriate mental health resources, patients were struggling and often turned to the ED for help in crises. For providers, very frustrated with their inability to get patients access to much needed mental health services. And you all know what this burden feels like, right? You work so hard to try to find a local counselor. You can't find a counselor, but your patient your patient needs access to these services. And so you inevitably end up taking on some of these services. I may have shared at a previous session that my wife is a psychologist. So I learned very early on in my career that I am not a trained mental health counselor or psychologist or what. So family docs, as we always do, try to plug holes and fill gaps and such, but we're not great at that work. I mean, we might think that we're good, but we don't have a lot of formal training in it. It's not a really efficient, effective use of our time, but again, we're stepping in to fill the gap. So hard for our docs who are trying really hard to meet the needs of patients, feeling like they're not doing that job really well and feeling like it's adding a ton of work to their plate. Payers didn't like that patients were inappropriately utilizing ER services. They did want to provide higher quality care to their members. Again, they call patients members. So again, some alignment around this idea. And then others. So Washington State, so this was maybe 6 or 7 years ago, Washington State was recognizing the huge shortage of mental health services and was starting to roll out programs to increase access to mental health. So again, an interesting time for us where we were seeing the problem that was also being seen at kind of a state level, and more resources we knew were being diverted in that direction. So what potential solutions did we come up with as an organization? So again, a handful. Like a reasonable idea wasn't clear how we would operationalize that second bullet point. Third one, launch our own embedded mental health services. So that's not a new model, but you put behavioral health with primary care. Obviously reduces barriers to access for our patients, makes it really easy and convenient for them. However, again, startup costs, again, a pretty significant barrier. We also had never done mental health as an organization. So again, different systems and processes all across the board. And that doesn't sound terribly complicated until you get into the nuanced weeds of scheduling and where notes are put in the chart and how do you bill for this and who's going to pay you for it and what CPT codes are used and what are the criteria around those and who manages mental health providers and such. So again, pretty steep learning curve there that was quite intimidating for us. So how did this play out in Family Care Network? So we actually decided that we were interested in trying to launch our own embedded mental health services, but as always, we needed to create a pro forma that would make this make sense for us. And startup costs were a huge barrier. So we went searching for grant money and found some through the North Sound Accountable Communities of Health. For those who don't know, accountable communities of health are spread across the state. I think they have funding from the state government, and they focus on healthcare related issues, basically trying to improve healthcare in the communities around the state. So we reached out and were selected for a grant that extended over a period of, I think it was several years. And that was a significant part of the startup costs. We also needed some content expertise. So we built a partnership with the University of Washington. They have a model called the AIMS model. Some of you may be familiar with that, which is a behavioral healthcare model that includes primary care provider, mental health specialist, and a consulting psychiatrist. And they really had kind of the whole system and process built out and just taught us how we would do that. So again, really nice partnership with them. I think they actually provided some of the consulting psychiatry resources for a period of time at no cost as well, which helped with the startup. And then we reached out to payers, and this was a big piece of it, as we said. You may know that mental health stuff is sometimes treated differently from an insurance perspective. We needed to get alignment with payers and understanding about how they would pay us, how much they would pay us, that it would be sufficient to cover the costs of this program. We were very explicitly just looking to break even on this and felt like that'd be a huge win if we could reliably, sustainably provide this to the community. So money from the North Sound ACH, expertise from the University of Washington, ongoing support from payers through adequate compensation. And then we launched it and started adding individual behavioral health specialists to each of our outpatient clinics. We don't years later quite have every clinic covered, but have the majority of them. And it's pretty great for our providers to walk down the hall and talk to the behavioral health specialist to tell the patient, yeah, you'll get a phone call in the next week or two and you'll get your mental health support right here in the clinic. You'll just come right back in. For some patients, we do it via telemedicine. But again, offering something like mental health services through an independent primary care organization, huge barriers, but you start to think creatively, who are the different stakeholders, where are the resources that we need, how do we reach out and align around the shared goal of providing better mental health care to the patients we serve. And again, we're able to pull together a bunch of resources to get this thing off the ground. So final case study from Family Care Network is around hospital service financial losses. So here's the problem. Family Care Network had an existing hospitalist service. We work in Whatcom and Skagit County. The sort of largest hospital here is Peace Health St. Joseph's Medical Center here in Bellingham. We have a full-scale hospitalist team that takes care of all Family Care Network patients when they're admitted to the hospital there. So we had that existing hospital service that had existed for many years. but was really financially supported not by the hospital, but by the organization as a whole, which meant that our clinic docs were essentially shifting some of their revenue to support the hospital as service. And it was kind of an interesting story because that deficit from the hospital as service was kind of slowly growing year by year, as you might expect. And year by year, our board of all family medicine clinicians reaffirmed a commitment to the hospital as service and the care they provided and such. And so even though the service was losing money, we wanted to retain the service to ensure high quality inpatient care and stronger continuity between the inpatient and outpatient settings. And I think, as you all know, those transitions of care for patients are really vulnerable times, right? Going into the hospital, coming out of the hospital. And we had always found that the inpatient service smoothed that over for patients and their overall care, let alone a pretty positive patient experience. So stakeholders in this problem, it's kind of the same list always in healthcare. So again, one of the take homes is you should always think about these different groups. So patients loved having their inpatient care provided by Family Care Network docs. You can imagine that. I used to work on our hospital service for years, and I'd walk in and say, I'm Dr. Anderson. I work with Dr. Brown near PCP, and you could just see their anxiety level come down. So that patients are very supportive of the service. FCN providers, our clinic-based providers, appreciated the quality of care and communication from the inpatient team. But again, we're financially supporting the service, and that comes at a true, tangible cost to them. Payers recognize that the inpatient care provided by FCN docs often resulted in fewer readmissions and a better patient experience. And again, that's kind of speaking their language, right? So readmissions translates to dollars and costs sometimes. And then patient experience is a meaningful thing. And then the hospital itself. So the hospital had historically received the benefit of having FCN and FCN inpatient team without providing any direct compensation to support the service. I kind of intentionally left out the long history of how we ended up in that place, but that's the place that we were in organizationally. And so the hospital was kind of getting all the benefit of having patients in-house and referrals to their specialists and procedures done in hospital without having to provide any compensation for the primary hospitalist managing the care of those patients. So options for us to continue, or potential solutions for us to address this. So continue with the status quo, operating the hospital service at a significant loss to FCN. Again, this has been reaffirmed year by year by our board, but those costs are real, and you worry as they grow over time. Shut down the hospital service. This would certainly have saved overall costs for FCN, but likely reduce the quality of care and the patient experience while increasing readmission rates, which again would just drive up healthcare costs in the system as a whole. Figure out a different financial model to support the hospital as service. It's probably obvious from my comments what we eventually thought that model would be. So there may be some other potential solutions. Those were the main ones that came to mind. We, of course, leaned into the third one, figure out a different financial model, because that's what we felt would be most appropriate. So how do we do this? FCN strongly supported the concept of an FCN-operated hospital service to ensure high-quality care and reliable communication around patient transitions in and out of the hospital. So we worked directly with the hospital to negotiate a contract that included hospital-defined incentives to ensure that our interests were aligned. So it's kind of an interesting conversation, because instead of just going to the hospital and saying, you got to pay us money, we've been doing this for free for a period of time, we went to them and said, we would like compensation, but we would also be very comfortable with you defining a series of incentives that align with what you need to succeed. And they said things like, well, we need to get patients discharged at a certain time. So one of the incentives was discharge orders written by 11 a.m. And the second one was readmission rates really matter to us. We'd like to reduce those. So we set some thresholds around readmission rates. And another one was Press-Ganey scores. And so we started to align around that as well. So it wasn't just, hey, you got to pay us, and a complete loss for them. It was saying, let's align better. You support us, and then we will support you to be successful in the things that matter to you as an organization. Now, still wasn't a super easy negotiation, but ultimately landed with an appropriate contract that continued to support the hospital as service moving forward. So I would also say that we have payers who very much appreciate the value of our hospital as service, and they also, because we continue to ask for additional contract incentives to support that service. So with some payers, it's kind of a fixed annual amount that they pay in just to support the hospitalist team. For others, it's based on some of the work the hospitalist team does. But again, we have no sort of shame in going to our payers and saying, these are the things that matter to us. We really think they should matter for you as well. They very much align with what you're trying to accomplish, and they will help you be successful as an organization. So help us help you be successful there. So again, another kind of good outcome for FCN around hospitalist services. So, all right, so those were the 3 case studies. I'm sensitive to time here. So we asked the question after the last session, are there any examples kind of from the audience that they would be interested in us weighing in? And so there were a handful cited. I'm just gonna dig into one a little bit, and then I'll give some quick thoughts on a few of the other potential problems that were brought up. So the one that came from that we'll focus on is around physician motivation for value-based care metrics. And so I will admit this was kind of a single sentence, so I extrapolated a little bit and made some assumptions around what this was about. So the problem, so physicians struggle to maintain motivation to achieve value-based care metrics. Physicians feel, I've heard this many times, so I assume this is correct, but physicians feel this is an added burden beyond the visit volume standards or quotas that they're already being held accountable for. So sort of that like, doctor, do more, doctor, do more, doctor, do more. Now you have these quality incentives and you got to work towards those and such. So stakeholders here, patients would benefit clinically from standard value-based care metrics, or excuse me, from the standard value-based care metrics. So I think we all understand preventive care measures have value. Effective chronic disease management is important. Managing utilization appropriately is important. I think that aligns with patient interests as well. Every patient I've ever met wants good outcomes and wants cost-effective care. And so clearly patients are in favor of this. Physicians, already overburdened physicians, feel like value-based care metrics are just one more thing added to their workload. And it's funny how historically, I mean, many of you, I'm sure, have had this experience that the solution to everything historically in healthcare was doctor, do more. And that is a horrific long-term strategy. So again, the way I understand it, a lot of these value-based care metrics are just kind of unilaterally placed on the shoulders of already overburdened physicians. Payers, so increasingly payers are measured by these value-based care metrics as well. So some of you may be familiar with the Medicare Stars program. So Medicare judges Medicare Advantage plans based on performance on some of these classic value-based care metrics on their patients. And then there are like true financial and some other non-financial incentives to achieve these metrics. So payers have a legitimate stake in this game, and they have like true skin in the game to ensure that these metrics are achieved. And then what about others? So healthcare organizations that often employ these physicians may have contracts in place to monetarily reward high performance on value-based care measures. So again, if you work for Swedish, it's possible Swedish has negotiated a bunch of contracts that say if we achieve these metrics, Swedish will be paid more revenue from the payers. Yet many of these employers, I think, as you all know, are feeling financially strapped due to ever-growing expenses. I'll save my commentary about how inefficiently many large healthcare organizations are run, but suffice to say they're feeling financial pressures, yet they know they would get rewarded from achieving these measures. So this is not going to have kind of an outcome because we're just kind of working through this problem, but some potential solutions and thoughts around those. So first, I would just make a note that these value-based care metrics are not going away anytime soon. I think you know that because you've participated in the previous sessions in this series, but this is going to continue on. It is a way that we as doctors and healthcare organizations will continue to be measured. I think we all know that value-based care metrics don't define quality care, but they are objective and they are measurable. And so they're used as kind of a surrogate for this whole kind of broad notion of quality. But the metrics are not going away. So potential solutions. So physicians just simply stop focusing on value-based care metrics. So sort of I revolt, I'm not doing it. I'm not gonna play that game. So while this may improve short-term quality of life for physicians, it comes at a financial and reputational cost to their organizations. Obviously, organizations want to receive those value-based care incentive payments, and they want to maintain a reputation of a high-quality organization. Physicians may also be subject to repercussions of such a decision, although if a bunch of physicians get together and say unionize, as is happening across the US, maybe those repercussions are mitigated in some way. Organizations offload the burden of achieving value-based care measures from physicians to other staff members. So I know some organizations around the country that have done this. They've basically said, it's too much to put that on the docs. We're going to hire an army of, they're often called quality care managers, but there's other names that they go by, care coordinators, care navigators, there's different terms that they use. And these individuals manage outreach to patients around standard quality metrics. And so this would increase the organization's expenses, right? Because they're paying for these added care, quality care managers. but hopefully that added support improves reimbursement because they achieve these incentive metrics, and thus more revenue comes in. So I think some progressive organizations have kind of done the math and said, you know what, we can make this pencil where we'll hire all these people, but we'll generate so much additional revenue that it'll pay for itself and then some. I still think there's a potential of a little bit of disconnect with physicians, but there might be some strategic ways to overcome that. And then the final one is that physicians, and again, this is not a comprehensive list, but ideas that came to my mind, physicians reach out to management asking for direct compensation for achievement of the value-based care measures. And this, again, this may be happening already, but acknowledging that both payers and the organization you work for as a physician benefit from higher performance on these metrics. I think it's very legitimate for physicians to say, hey, we're doing the work. It's good for both of you. Let's create some type of program where we benefit for the good work that we do. And again, I think this exists in some organizations. I think, as you know, I've never been an employed physician, so I've not negotiated these types of contracts. But again, this type of quality bonus, quality incentive program can take a bunch of different forms, but it's recognizing that it's highly beneficial to both payers and the employer organization to achieve on these measures. And so docs basically say, hey, we're doing the added work, it's added burden on our shoulders. We have to be compensated and rewarded for this additional work. So again, a bunch of different ways to go about this, but it's I think that sort of basic statement like, hey, this is not fair, you can't ask us to do more, that doesn't get any traction anywhere, as at least has been kind of my experience. And so, that sort of moral argument or ethically, this is not the right thing to do, or this is unfair to us, or what. And my experience has been that doesn't get a lot of traction because it's not really the game that executives and healthcare organizations or payer organizations are playing, right? But if you speak their language, like, hey, we know this drives revenue. Hey, we know this is good for your quality scores. This is good for, a Medicare Stars program or something like that. Then you're speaking their language and you can advocate for the change that's potentially helpful for you. So just some thoughts there. And then, in meeting with organizational leadership executives, physicians should start by seeking to fully understand how exactly the organization is paid. And again, that's a really important concept. I would not make too many assumptions about what type of value-based care contracts are or not in place. But if you're able to meet with leadership and say, how exactly do we get paid? And, you're telling us to do all these things. Why do they matter to the organization? And if they tell you, well, it's good for patient care, be like, yep, I know that's true. But what does it mean financially? What does it mean monetarily for the organization? And again, hopefully they'll be somewhat transparent around that, at least enough that you've got some ammunition to build an approach around. So, all right, quick thoughts on a few other issues affecting family physicians. So just 3 other issues that were raised, and I'll just share some quick thoughts, and then we'll try to wrap this thing up. So one comment was around increased staff turnover due to poor compensation of our support staff. And so again, it's easy to just, again, say, not fair, this is not good, we need to pay people more money, this is not reasonable. That's not the perspective the executives are taking on these issues. So leadership, usually the executives, should understand that staff turnover affects both quality and productivity, thus impairing revenue, right? So to say, the problem is not just that you won't pay somebody anymore, it's that if you don't pay my MA enough, and he or she leaves, I can't see nearly the number of patients and I can't generate nearly the amount of revenue for you. And I know that as a full-time family doc, I probably generate $500,000, $600,000, $700,000, $800,000, $900,000 of revenue for the organization. So, a 10% reduction in my productivity, it is way more cost than the cost of paying, my MA an extra $1 or $2 per hour, or something like that. So I'm advocating for a method potentially to prove this. So if there's some type of study around productivity with staffing changes, that'd be interesting. And perhaps physicians assume a little more accountability for quality and productivity. So again, it's always risky to make guarantees, but thoughts around, if we can raise expenses just a little bit, we'll prove to you that we can achieve higher quality and we can be more productive and such. So again, I'm kind of a believer in, as docs, assuming accountability for the things that we can control. So next one was around prior authorization burden. I figured this one would come up. I could have done a case study from FCN around this. So prior authorizations, so recognizing that prior auths exist merely to corral total healthcare costs. And again, that's a real important statement. I shared in one of the previous sessions that a VP at a well-known payer looked me dead in the eye and said, we only have prior auths for one reason. We're just trying to control what happens in the exam room from behind the scenes. And it's because they want to reduce total costs. And I thought, it's crazy. But recognizing that that's what they're trying to do, manage healthcare costs, explaining to payers, and this is the approach that we've taken at FCN. We've gone to payers and said, prior auths, terrible for patient experience, drives up costs on our end, reduces capacity to take on new patients and new members because we're so busy trying to sort through these prior auths. It's just a huge waste of time. And so what we've done is ask a couple payers for essentially a trial period of removing prior auths while tracking utilization. So the big fear from payers is if docs don't have prior auths, they're going to order MRIs on every human being that walks through the door. And we all know that's insane. That's not going to happen. But we, with a couple payers, have gone and said, let's strategically remove a few prior auths. Referrals to a handful of specialists is one that comes to mind. And we said, let's track this thing over the next year or two and see if we make more referrals to these specialists without prior auths. And guess what we found? We don't make any more referrals to the specialist. So, so again, the sort of explicit agreement with that payer was, we'll track this for a period of time. If our referrals shoot through the roof, we'll reinstall the prior auth process because we're not managing it appropriately. And of course, once they agreed to that plan, we went to all the other family docs in FCN and said, essentially, don't screw this up. You don't have prior auths any longer. Don't abuse that. Don't refer every patient if it's not a necessary referral. And guess what? Our docs, of course, continue to provide appropriate care to patients. So obviously all prior auths should disappear. That would make our lives so much better and patient lives. The last one was around physician work-life challenges. This is a complicated issue, but ultimately my belief is you'd like physicians to have some choice and autonomy in how they work. And I just put in parentheses, in return for changes in compensation. I have heard stories of docs saying, well, I want to work half time, but I want my salary to stay the same. And I think you all are smart enough to realize that doesn't make any sense financially or economically. But again, if you allow docs to adjust their FTE and say, well, that affects your compensation, but you have some freedom to do that. I know some organizations say, nope, we hired you for a full-time position. That's all we can ever do. I would just remind leadership, the executives, of the growing and anticipate continuing to grow national shortage of primary care providers, and that allowing some flexibility will increase overall physician retention and thus revenue. So, if the option is let the family doc go to 3/4 time or fire them or have them leave because they're so frustrated, it's very short-sighted to not allow family doc to make that change. I mean, in a long game perspective of the organization, you ought to retain as much primary care as you can. That's the whole key to this value-based care model that continues to emerge. So again, with all of this, the hopefully resounding message, and I hope I don't sound too much like a broken record, is think about the other people involved, think about their perspective, and frame your request in a way that will resonate with others. So, all right, that is it for the case studies. We'll wrap this series up with 5 take-home concepts from the Business of Medicine series, and then again move to the question and answer. So number 1, challenge facing healthcare is not really clinical. It has to do with the business of medicine. It's everything that happens kind of outside of the clinical care. And for all the reasons we've outlined in the last 6 modules here, our definition of success, great patient care, has been blurred and muddied and convoluted and resulted in decisions that are harmful to patients and physicians. You all have lived that for years, I'm sure. Hopefully this series has helped make sense of why that has happened and why it continues to happen. If family docs understand the business of medicine, in quotes, we are uniquely suited to create positive change in the system. We must frame our proposed changes in ways that resonate with current healthcare leadership. And I really think fundamentally the problem with healthcare in the United States is it costs way too much, and embedded in there is probably overutilization. And if you ask the question, who is going to control costs in healthcare? It can't be the insurance companies. They try to do that with prior auths and such. It's not going to be the specialists. I mean, I've met very few specialists that are like, yeah, we really have to rein in costs and procedures and such. I mean, surgeons like to do surgery, right? And so I really think it has to be the primary care providers that can drive this. We build these longitudinal relationships where we can help patients navigate through care in ways that align with their personal goals, but are also cost effective and ensure high quality throughout. So we are just very uniquely suited to create positive change in the system, but we have to understand how the whole system works from sort of a business, economic, operational perspective. The future of healthcare is family medicine or primary care more broadly. We've talked about all the legislative changes, increasing percent of healthcare spend in primary care, that new G code 2211, which reveals that CMS's goal is to get more money in the hands of primary care providers, the new Making Care Primary initiative, which is the exact same model. So everyone's really starting to align around this concept. And I think you should feel hugely encouraged by this. Excuse me. I had the privilege this past weekend of going down to Renton and talking with a bunch of third-year family medicine residents from around King County and beyond, and just telling them now is a great time to go into family medicine, like maybe the best time, maybe a better time. I mean, I've been in medicine now 20 years, maybe the best time in my career to go into family medicine. Like your future is super duper bright, and you should feel really good about the choice you made to pursue family medicine. Number 4, you have more power and influence than you realize. Healthcare does not work without primary care. Full stop after that, right? Primary care is absolutely mandatory to make healthcare work in any semblance of a reasonable fashion. And so just understand the power you have. I think one of the challenges is primary care docs for decades have kind of been shoved down like, you're just primary care, you're just a family doc or whatever. But like none of our healthcare systems run without us. That's a really important statement. And so in that comes huge amount of power. So advocating for patients as you advocate for yourself, and leverage that power. I mean, you get all the primary care docs or all the family docs together to advocate for change, pretty high likelihood that change will happen. And honestly, if at a certain point change doesn't happen, we get to vote with our feet, right? So we can walk out the door and leave if we're not seeing the things that we want to happen. And then last, and this is just kind of a personal plug, but at the appropriate time in your career, consider pursuing leadership and advocacy. Everybody wants to hear from a family doc. I'm meeting with the state senator next week, and for those of you that don't engage in advocacy work, it's that people are suspicious of the healthcare industry, right? Costs have skyrocketed and such. People, as a general statement, are not suspicious of family docs. They like sincerely want to hear what we think. They know that we probably didn't choose family medicine for the money to get rich and such, that we were genuinely interested in taking care of patients longitudinally, serving our communities and such. And so there's a lot of base sort of inherent credibility that's given to family docs. So, you know, my long-term sort of pipe dream vision is that every major healthcare organization is run by a primary care provider, preferably family docs. We've got a bunch of them in politics and such. I'm really revamping how healthcare is done from a very, very fundamental perspective. So those are 5 closing thoughts. Let's move into question and answer. So I'll turn it over to Jordan.